No sense at all. So 0 sugar in the urine is normal. If you got sugar in the urine, that is abnormal. And what is the renal threshold? Usually in persons without diabetes, renal threshold for sugar is what? 180 milligrams per deciliter in the blood, right? Okay. Once you exceed that, then you will start to see sugars showing up in the blood because you've saturated the system that can no longer get it all back into the bloodstream, absorb it. So there are transport molecules, and they are SGLT1 and SGLT2. They're located in proximal tubules, and they reabsorb sodium and glucose into those proximal tubule cells, and then puts it back into the blood. So those, you see, there's those blue tubes. There they are, and they're going to transport the glucose out of that proximal tubule cell back into the bloodstream. So these drugs, these SGLT2 inhibitors, inhibit that process. A couple of things on this slide. The amount of sugar that gets excreted in a day when these drugs are used is proportional to how much you filter. So if people's blood sugars are fairly high, they will get rid of a lot of sugar. And it is independent of insulin action. Okay, so what did I tell you about insulin action? If we have a drug that affects insulin, what kinds of things can you expect? Okay, weight gain, but what would be the biggest thing you would worry about? Hypoglycemia. Always keep that in mind. So this one doesn't do that. Does some other stuff. Okay, so this one is in your packet. So this is showing you that you're producing about 180 grams a day of glucose, this person is. Filtering it all ethical Mariolus, 90% of it being reabsorbed by GLT2, so it's the predominant one, and then some by GLT1 further down the proximal tubule. You see this renal gluconeogenesis? We don't talk about it very much, but the renal cortex can make new glucose. And it's fairly active. It's about equivalent to what the liver can do. So it is not as well worked out, and it isn't factored into the pathophys of type 2 or of any diabetes as much as we talk about the liver. But it probably is on the same scale as the liver in terms of being able to make new glucose. So that glucose can also be, that production of glucose can be significant and add to the problems of high blood sugar. And so this also kind of helps get rid of that sugar that the kidney is producing. So normally, 100% is reabsorbed, no glucose in the urine. So this is a little bit prettier picture. And it shows you all this sugar that's not getting reabsorbed. So what would you expect to happen to weight? So people can lose weight on this drug. It's modest, but it's possible. If you're losing enough energy a day, then that could happen. So you can imagine some of the side effects of this drug. One is urinary tract infections. You increase the sugar milieu where it's usually not, and so that is one of the problems that can happen with this drug. Page 18. So what can you expect about a 1%? So they're on the equivalent to the low end of what you can see metformin and the sulfonylureas do. So clinical effects, you're excreting about 50 to 100 grams a day. So how many calories is that? How do you figure that? How to get 200 to 400 calories? 4 calories per gram, right? So how long would it take you to lose a pound if that's how much you're getting rid of every day? 2 to 3 weeks. So how many calories in a pound? 3,500. So you divide that by the 200 to 400. So 17 to 9 days, 9 to 17 days. You also get a slight osmotic diuresis because you're excreting glucose, then water will go with that. That can be problematic in older people. Blood pressure drops have occurred. So here it shows you that the average reduction is about 5 millimeters of mercury in systolic and about 2 in diastolic. But some people can get into trouble with it. So if you've got somebody who's very well controlled or runs low or has orthostatic hypotension, you need to kind of keep that in mind, factor that in. So these drugs came out after the FDA started requiring drugs to look at cardiovascular risk or cardiovascular effects or outcomes on cardiovascular endpoints. So one of them, Jardiance, has been shown to reduce cardiovascular and all-cause mortality when added to standard care. Because of this data, they have kind of moved this drug up, they being the ADA and the expert consensus panels that come out. They have recommended this drug come into a second place after metformin. I have my, I'm not real sure about that. I'll just tell you, they are expensive. How much do they run, Kristen? Do you remember?
Not off the top of my head, but even with insurance, people were paying at least $100 a month for a.
That's copay. Yeah, they're several $100s for a 1%, and I can get $4. I can get 1%, 2% with metformin. You would add this on to metformin, but it's a lot of money for the percent drop. Plus, there's lots of side effects with it, and you must pay attention to renal function when you use these agents. If you look at, I think I put it on first. Yeah, go back to page 16. So if GFR on Invokana, GFR is 45 to 60, then it limits the maximum dose. You see the max dose is 100 to 300. And if it's less than 45, don't use it. Some of this goes to if you don't have a high enough GFR, you can't filter enough sugar to make it make a difference. See, so it goes to efficacy more than toxicity. With Farxiga, it is a GFR of less than 60. So a lot of your diabetics are not going to qualify because I can tell you like your middle-aged diabetics, type 2s, who've had this for a while, are going to be in that ballpark already. And then Jardiance, less than 45 use is not recommended. So kind of keep that in mind. That goes to a stage 3 CKD, chronic kidney disease. You'll see that they're usually taken in the morning and given once a day. Usually you start at the low dose and then within a few weeks or a month you move them up to that second dose if you're not getting the effect you want. Okay.
Dr. Cassie, was there any info about Invokana's lawsuit coming out about the amputation? What to say about that?
I don't know that I put it in the, I'll talk about it. Study in tolerability, cardiovascular impact, the other two things. So for Invokana and Farxiga, their They may reduce some cardiovascular risk. But you have to treat a large number. You're getting into like a number needed to treat is 70. But the experts coming out now are believe that that is a value to consider in your patients who have cardiovascular disease and diabetes already. Safety and tolerability. Increased risk of yeast infections in women. Increased risk of urinary tract infections. Can increase the risk of hyperkalemia, especially if you've got people that are on ARBs and ACEs. Symptomatic hypotension, so there it is, the higher risk in the elderly. Renal impairment. These drugs can worsen renal impairment in some people. So monitoring the kidneys while you have them on it is important. So increased risk of acute renal failure. Decline in hemoglobin and hematocrit. I didn't put down the amputations, but Farxiga has, we were doing the studies on Farxiga at Harold Ham 10 years ago, and that drug almost didn't make it to the market. It had lots of problems. They sent it back for further study, the FDA did. So it got delayed about 2 years after it made its new drug application. One of the problems with that drug is that there is an increased risk of amputations in the patients who take it. It's small, but it's significant enough to be considered reportable. Lawsuit I didn't know about. You mean like a class action?
Mm-hmm. Yeah, it's all over. I guess I watch old people programs or something because it is all over the networks that I watch.
The lawyers advertising for a class action.
If you've had, if you had an amputation, you were on Indocana,
it does one other thing that makes me a little nervous is it causes a very atypical DKA. So diabetic ketoacidosis occurs when you usually don't have enough insulin to suppress fat metabolism. So lipolysis occurs, fatty acids get broken down, the liver takes them and converts them into ketones. It converts them into ketones to the point where it overwhelms the ability of the body to buffer them. They're organic acids, and so they eventually lower pH. So in most people, we usually see this in people with type 1. And we usually see it when their blood sugars get really out of control, like 400 or 500. This is atypical in that these people usually are developing DKA at levels of around 200 blood sugar. They also are not insulin deficient, which is really odd. And the symptoms can start, or usually they start early, but and it shows you there the mean onset was about 2 weeks. When this originally started happening, people missed it because you don't expect it. You don't expect a type 2 with fairly not moderate levels of blood sugar, hyperglycemia, to also have DKA. Here are some of the symptoms. It usually makes people very sick, though usually within 24 hours they're vomiting, abdominal pain, very, very common. Rapid breathing comes about because they're producing these ketones. And the acetone in particular drives their respiratory. So one of the ways you get rid of ketones is you increase respiratory rate. Okay? That's why that musky smell that they will describe that some diabetics will have is due to that acetone that they're trying to get rid of. So that's one of the ways that the body can get rid of an acid load is to increase respiratory rate. Pulse goes up because they get dehydrated. They lose, usually people in DKAs, type 1s, lose about 5 to 6 liters of fluid before they ever get to the hospital. One is because they're vomiting, the other is because of the polyuria. Okay, so they get sleepiness comes just from the assault on the body. Dry mouth goes along with the increased pulse, dehydration. Flushed face, I'm not quite sure what that's from. And then the fruity breath is that ketones. Okay, so this would be a typical presentation. Type 1 comes in with these symptoms, you're automatically going to think DKA. But this didn't happen in this case, and people died. People died of this syndrome because it wasn't recognized. So now that if you put these people on it, one of the things you need to do is educate them about that. If you begin to have these symptoms, you need to seek medical care right away. So here is the atypical presentation. Glucose levels mildly elevated, less than 200. High anion gap, I'll show you that in a minute. Elevated blood or urine ketones, almost unheard of at this level, at these usually levels. Triggers identified were a stress, and this is what we'll see in type 1s. Usually there's a stress that brings it on. Usually a GI bug is very common, or they just quit taking their insulin for a few days. So major illness, reduced food and fluid intake, reduced insulin dose if they were on insulin as well. In half the cases, no identifiable trigger, and most of the patients were type 2. So anion gaps, what's an anion gap? Well, here's normal. So what's the difference? Here's your cations, right? So your major one is sodium, a little bit of potassium, then you've got unmeasured cations. Then your anions are chloride, it's your major one, and bicarbonate. Then you've got these unmeasured anions. But electrically, we're neutral, right? We don't have any little zing about us or any charge that we give off, right? Most of us. So there is a gap in between the measured anions and cations. See, right there. So what's a normal anion gap? I think it's about 5 to 10. Okay, so here's a normal gap. So you get different types of acidosis. From different causes will produce either a normal gap, anion gap, or they'll have an elevated gap. So in this case, you get an elevated gap. So look at the difference between unmeasured cations and unmeasured anions. It's huge. You lose bicarb because you're consuming it through the acid-base process. So it would be one of the labs you would look at that. You would order an anion gap on your profile. Okay, so that's one of the markers. So educate the patients to, especially at the very bottom, if they develop nausea, vomiting, lethargy, abdominal pain, rapid breathing, change in mental status. That would be a common thing. For this reason, I use this drug in practice, but I never found it to be that helpful. I never found people to get that low of blood sugar or to get that much change, especially for the money that they were having to pay. So I didn't use it. I didn't have a lot of experience with it because I just didn't find it of use in the population I dealt with. So take it from there. But I'm telling you, they're elevating it to think about it as a second-line agent. I think it'll depend on where you practice as to whether you'll see it or not. I don't know if insurances will go along with that because it's a lot of money. A lot, and there's a lot less expensive items that you can use in its stead. But that is the reason for it. And so you're going to be great fodder for the salespeople for the different drug companies. Has Dr. Britton talked to you, giving you a spiel? Okay, you'll be like fresh meat. And so if they can get you cornered and they can talk to you, they will. And so you're going to hear this line from them. And they are correct in what they say, but how you use that in practice has been more up to you. But realize they are selling you a line, And then their evidence is they can only say what the FDA has approved them to say. Okay? So their evidence is true, but you have to look at it in the greater context as to whether it fits for the people that you're taking care of or not. So, questions about that? So only my opinion. But when I look at big time problems that a drug causes and what I get, I weigh it heavily as to whether it's something I would use or not. That's the way I look at it. So patient education, we talked about that. Okay, as the healthcare provider, if you have somebody come in on SGLT2 and they're not feeling good, this would be on my list until I could knock it off, until I could rule it out. Okay. Okay, page 19, you haven't seen my little red flag warning in a while, but the big thing is what should go up in your brain is check renal function, particularly if you're dealing with older, middle-aged, type 2 diabetics. There's two other drugs that have been approved for use in diabetes. I'm not going to test you on them. They're not used that often. Colesevelam it is a drug that will improve lipid profile. So I think it's one that I would consider like an added plus, especially if I needed lipid lowering in addition to statin. I would think about this drug. It's a bile acid sequestrant. It will lower A1C about 0.5%. So it's not powerful. But it has an additive effect in addition to treating another comorbid disease that diabetics often will have. Because it's a bile acid, this one is actually better tolerated than the other two we talked about. Remember cholestyramine we talked about and cholesterol? This is a third one in that category. It's a whole lot better tolerated. Those are hard on the stomach. They can cause bowel obstruction if you're taking large doses. They can increase triglycerides. That's one of their drawbacks. If you're going to prescribe them, they come in tablets or packets, so you can use them as powders or tablets. The last one is bromocriptine. So when we talk about, let's see if we talk about that drug at all. We'll talk about it with growth hormone. We'll talk about it. It is also approved for another pituitary indication. I'm blanking right now. But we found that when we used this drug in people who had gigantism or growth hormone excess, that their blood sugars got better. So this is an old drug. It's been around forever. So it's one of those to just consider. I would never use it first line. I wouldn't use it second line. I wouldn't use it third line. But I'd keep it out there if I was running out of items to use. So bromocriptine. And when we talk about growth hormone excess, we will talk about this drug. One of the good things is it doesn't cause hypoglycemia. It is very modest too. It's probably under 1% in terms of its impact on A1C. Very last page. Children with type 2. For the most part, very few of the drugs have any data on them. The two that do would be insulin and metformin. If you're dealing with type 2, kids with type 2 that do not require insulin, then metformin is the way to go. There was a large study called the Today study, and the OU Med Center kids endocrine group was a large part of that. So we have we've added a lot to that information because of the population that we have in this state. So with type 2s, a lot of it is you want to go after lifestyle, you want to go after weight loss, you want to go after exercise, you want to go after the family in terms of how to change lifestyles that are healthy. But metformin can be used, same kind of dosing we talked about, starting with 500, testing their A1Cs on a regular basis, just like we talked about here. Kids have different A1C goals than adults. We allow children to be higher because we want to avoid hypoglycemia. We'll talk about that when we're looking at type 1s. Children usually, even if they've had type 1 for a long time, usually the clock does not really start counting on them for complications until they go through puberty. So there seems to be a protection or a grace period. I don't know what the reason behind it is. But because of that, we will allow higher blood sugars because we don't want them to go low because of the effects on the neurologic development. So that's at the bottom. So at the top, if children are presenting and they are acting like they are insulin deficient, then we start them on insulin. So a lot of kids are, not a lot, some people and adults who are truly type 2 will present in DKA. So sometimes in the beginning it is hard to figure out exactly which type they are. It does not matter what they are though, we always treat the patient. Eventually you'll figure it out. Eventually it will become, you can use C-peptides, their blood sugar will go down to normal. And one of the reasons is there is a state called glucose toxicity. When the blood sugar gets above 300 and stays there, I don't care if you have type 1 or type 2, if it stays there, it makes the beta cells sick. And so they call that glucose toxicity. So here's what you'll see. You'll see somebody come into the hospital, their blood sugars are going to be 500. They're sitting there looking like a type 2, they're overweight, they're a high-risk ethnic group, they've got a big family history of type 2, but they're sitting there and they're peeing a lot, they're losing weight, they're very hungry, and all that's screaming at you is that I cannot make enough insulin. So often what will happen is if you will treat them with insulin and get their blood sugars down below 300, more near normal, at least 200, over a period of a few weeks, those beta cells will recover some of their activity. And usually those people will be able to go on to oral agents and lifestyle and manage fine without insulin. So it's called glucose toxicity. Makes the beta cells sick. They can recover, but you got to get the blood sugars down. Yes?
If it's elevated for a really long time, is it possible they won't recover, or do they always bounce back?
They always recover to some extent. Unless they're a slowly evolving type 1, which there is a type of diabetes called LADA in adults. It's a latent autoimmune onset of type 1 in adults. And their immune response is just slower. Kids, it's pretty fast. It's a matter of months. In adults, it can be years. And so they call it LADA. And so eventually they run out of insulin and they have to go on these. Okay, any questions about the oral agents? All right. Let's take a break and we'll come back and talk about insulin.